Hausman from the ALS Association, Greater Philadelphia chapter. Janie Eskovitz, social worker, and I are going to be talking about Adele Jacobs, another fictitious patient. This patient in particular has the familial form of the ALS, and she tested positive with the C9orf gene, which is the most common form of the familial form of ALS. It's also a form that's associated with cognitive impairment with ALS. And as I stated in when I spoke about Adele in length, we had done the ECAS testing on Adele, and it turns out that her significant other, John, identified 2 areas of behavioral concerns. One is excessive spending and possibly a decrease in empathy towards him, which he says both are out of character for her. So most likely, based on this screening tool, she probably has some impairment. It's not definitive because she hasn't had formal cognitive testing, but she's showing signs of the behavioral variant of the cognitive impairment associated with ALS. There are different variants. There's executive functioning, which is like thinking, judging, reasoning. And then there's the language variant, which is problems processing language and utilizing language effectively. And then there's the behavioral variant. So what I would recommend to Adele and to her significant other, and in discussion with Dr. Ilieva, is that Adele might want to pursue formal cognitive testing. And with that, it's 4 or 5 hours of testing. There might be a brain scan, but that would be with a neurocognitive doctor who specializes in this and can say for sure whether or not Adele does have definitive cognitive impairment associated with ALS. The reason that we would recommend that is because some people need to have a definitive diagnosis, that it's not enough, just a screening tool is not enough. And also as far as treatment goes, because if Adele does have the cognitive impairment associated with ALS, then there might be some medications that may be of help if she develops certain symptoms, for instance, agitation. And then there's a doc involved who is a specialist in cognitive impairment. So it would be like a second physician working with Dr. Ilieva with that. I might want to meet privately with John, the significant other, about this, or with John and Adele, depending on how Adele responds to me or how she seems. I would also encourage them to register with the Association for Frontotemporal Degeneration, AFTD. AFTD is a national organization. It's a nonprofit, and they are involved in research for FTD, which is frontotemporal degeneration, and they are also involved in providing some resources for people that have FTD. When I talk about the cognitive impairment with ALS, it's usually mild. The extreme form of cognitive impairment would be frontotemporal degeneration, okay? But a lot of times people have more of a milder form of that. But you can still register with AFTD and receive the services. So for instance, I know AFTD has a grant program, and they have various in-services that they provide and support groups. Just a statistic, about 10% of people with FTD go on to develop ALS. So there's a genetic link between ALS and FTD. Janie?
Yes, thank you, Gail. So Adele has been coming to the clinic, and because she is experiencing some ADL challenges in terms of bathing, dressing, and grooming, we've been able to connect her with the ALS Association in Abrams program, for which she is currently getting 9 hours of care a week. So if her husband is feeling that he needs more assistance, especially because the caregiver is now working at home remotely and her cognitive issues may be more challenging for him to monitor, he may need more assistance. Now, the ALS Abrams program provides 12 hours of care per week. So we may need to talk to the caregiver about what happens when the needs are greater than 12 hours. What types of resources do the family have in terms of bringing in more help as care needs are increasing? I don't believe at this point that the family qualifies for government state funded assistance. So this is going to be basically out-of-pocket expenses. And how can we help the family be creative in ways to find help in the home? Well, we can mobilize some informal supports, perhaps. We know that this young lady was employed at Merck. We know that Merck is a big company. Perhaps there are some resources available through Merck. Perhaps we could look for a fundraiser to raise funds so that this family can have resources available to get more help in the home setting. The patient has Medicare. Her supplement is Aetna. None of those insurances right now will pay for any type of the care that she needs, because right now it doesn't seem like her needs are skilled care. They're more care in the sense of supervision and assistance. I will continue to keep in touch with the family to see how they're doing. I will encourage the caregiver to perhaps join my online caregiver support program, especially since he's working remotely and may have the availability to do that from home. I'm also going to be a little worried about him because the impact of his wife's care needs may be great, and so much that this caregiver might need a little bit of respite. So I might talk to him a little bit about the respite program provided at the ALS Association. I would also encourage them to take part in some of our social activities, such as Longwood Gardens, Caregiver Retreat Program, the holiday party, and any other type of education or social gatherings that our organization can provide. I'll continue to maintain contact with the family and assess their needs for my contact with them.
Janie and I would both also be concerned about the son, make sure that he's coping okay, and if there's anything that we can help with that, as far as like referring him to a counselor, perhaps.
Yeah.
We're done, Tone.
My concerns for our next patient, Adele, is in relating to her numerous symptoms of swallowing, speech, shortness of breath, difficulty lying flat, difficulty tolerating her mask at night, and her cognitive and mood issues as well. Her falls raise serious concerns for safety, and I would be assessing her also for weight loss as well. I would probably start out exploring her issues with adherence to therapies. What are her views on it? What are her challenges? What are her difficulties? And what are her priorities for her treatment? I would assess her concerns regarding treatments and therapies and allow her the time to express her emotions regarding her challenges. I would also then take the time to assess her caregiver concerns as well. My primary concern would be, what are the patient's goals for her care? What are her thoughts about her nutritional and respiratory support? How does she feel about advanced treatments? Has she ever discussed her care goals? with her significant other. And if not, I would encourage that discussion in that meeting. My priority would be to collaborate with the team here regarding her determined goals and create some patient-oriented interventions that respect her goals. And decision regarding salivation, excessive salivation, swallowing, nutrition, and home safety would have to be discussed, but from a patient-centered perspective.
So this presentation is a presentation that we see fairly regularly in the clinic, and it's one that shows somebody who is fairly medically stable, but is beginning to experience some functional impairment, as well as secondary effects of ALS. And I say early just because he's having just some difficulty with cramping, and then also with doing dexterous or fine motor movements. And those are things that we often see earlier on in the disease, and unfortunately sometimes those deficits become even more pronounced. The cramping that we see a lot of times often is involved or provoked the more someone tries to use muscles, especially those muscles that are involved or that are weak, as is the case here when he's using what we call the intrinsic muscles of the hands. They're muscles that normally aren't as strong as muscles in our arms or our legs, and are actually prone to fatigue, but doing repetitive motion, doing motion that requires activation of them can produce symptoms. And a lot of times these are the symptoms that they have. They'll have cramping while they're using them. They'll have excessive soreness after that. The other thing that this patient is experiencing is one that we hear about a lot is what is pain, usually in areas where there's already a lot of stress. So typically where we see this is in the shoulder girdle, and then also in the hip girdle. And it's most likely biomechanical in nature. What we as a group really try to figure out through talking with the patient and then through our evaluation of them is exactly that. What about their history might indicate that this could be maybe an underlying issue, such as a chronic painful condition? Could this be arthritic in nature, or is this more biomechanical and potentially maybe an overuse sort of presentation that we often see when there's weakness of the postural and or stabilizing muscles. One of the things that I really like to partner with patients to do is, if we do identify this, there's lots of things that we can to do to try to make it more manageable and potentially to prevent it from getting any worse. A lot of times that involves postural correction, some courses of therapy to look at doing range of motion and trying to do things in a way that protects function and prevents further injury. And then unfortunately, if those efforts aren't successful, what we can recommend is bracing to try to take some of the biomechanical strain off of those muscles. And then even still, if there's not a response to that, there's interventional things that can be done. And for many of our patients, those are very rewarding when an intervention is introduced that can provide pain relief, where a lot of our other efforts or potentially some of the pharmacological agents that are out there may not be as effective for treating this as an intervention is.
Hi, it's Elisa, and I'm here with Jana Carroll, and we are going to be discussing our case study, individual with ALS, and we are going to begin with Ms. Jacobs. And we have her information here on the slide, and I'm going to make it bigger. There we go. And so we have, from looking at this, an individual who has some speech and swallowing problems. And so I'm going to start with Dan, and he can talk about how an SLP, which is speech language pathologist, will do an intervention, and then we'll go to Carol with dietary and nutrition. So go ahead, Dan.
Okay, so here we have Adele. She's a 42-year-old female with familial ALS. As you can see, that her forced vital capacity and NIF show that she's pretty far progressed. She's having some choking with liquids and some food. She's already modified her diet. At least if you can go to the next slide. She's having some trouble with her secretions. So a lot of times what we do with patients with trouble with their secretions, we usually start off with atropine drops, which can help minimize some of the secretions by putting a couple drops under the tongue of the atropine drops. Next, we could also move on to pharmacological agents, which can also help with the secretions. As far as her diet goes, she's already modified her diet. On the next slide, you can see that she gets short of breath when she's eating. And from this information, we can presume that she may have had a weight loss, maybe lost a bit of quality of life when it comes to eating and drinking. So usually at this point, what we would do is we would discuss with the patient the idea of what a feeding tube is and how that works. Generally, I think that the idea of a feeding tube is stigmatized in that people think that the feeding tube is the thing that you do as a last resort, or it's the end stage of the disease. But a lot of times with a disease like ALS, it's not quite that. The way that I like to look at it is something to help optimize quality of life. And that for somebody who's struggling with their secretions, struggling with swallowing, struggling with eating various consistencies, and also getting short of breath and losing weight, eating starts to become a bit of a chore, a bit of a, something that takes, a lot of energy, a lot of time out of the day. So with a feeding tube, we can look at it as something to help optimize difficulty swallowing by being able to add extra calories, extra hydration without having to rely on the mouth or throat route for getting nutrition in. With a feeding tube, I think it is really important to highlight that you are still able to eat and drink with a feeding tube in place. You're able to eat for pleasure. You're able to eat as much as you'd like, but you don't have the pressure of eating as many calories and putting in all the work that you were doing previously to maintain your weight and your nutritional needs.
And Dan and Carol, you guys often ask, how long does it take someone to eat, right? And what are your triggers if somebody says it takes me an hour?
Yeah, so I look at swallowing with ALS patients, from two different standpoints: nutritional and actual swallow function. Swallow function being the actual mechanics of the swallow, whether a patient's having food or liquid go down the wrong pipe into the airway, which is called aspiration, or having difficulty chewing or moving food around their mouth or keeping food in their mouth. Those would be the mechanics of the swallow. So I usually try to tease out what the level of dysfunction is. But then also there's other things that I ask about to maybe look for other red flags, such as if somebody's saying that it's taking them a long time to eat, it's taking a lot of effort to eat, the shortness of breath leads to choking, or people feel like they're just eating, and they're not really gaining any weight, and they really can't put their finger on really what it is. That would be one of the more nutritional dysfunctions or swallowing dysfunctions that are usually associated with nutrition that I look for. And that's, at that time, it's usually where we start to introduce the idea of a feeding tube.
Yeah, and with Adele too, I think she was having trouble with liquids, swallowing liquids, choking on liquids. So you have to look at hydration. A lot of patients, even before having an issue with actual food, they'll have an issue with thin liquids, and And if that's the case, and even thickened liquids, if they thicken it, that doesn't help, then dehydration can set in. So a lot of patients will get a tube feeding just for hydration purposes, unless they need it for food as well. But I've had a lot of patients just get the tube feeding so that they can give themselves fluid, bypassing this area.
And what about pills?
Pills can be crushed and put through the feeding tube, or they can get a liquid form of the pill. So they just have to make sure that tube feeding is flushed. And what I will do is I'll figure out their nutritional needs, put the order in for the specific formula that they need, and then send nurses to the home so that it's usually an in and out procedure one day, and they go in and get it done, go home the next day. The nurses will come, show them how to care for it, show them how to actually do the feeding tube. But it's usually what I will have is patients come back and say, I wish I got that earlier, because it takes, like Dan said, it takes the pressure off of them to always eat and eat and eat and get that nutrition in. They know that they're getting their nutrition in. So if they want to have that piece of cake, they can have that piece of cake and not worry. And if they're having a good day and they are able still to swallow, they don't even have to give themselves the formula that day. But if they're having a bad day, then they know that they can give, their tube feeding formula and not have an issue. So in Adele's case, I think that's probably what we would recommend at this point, a tube feeding, since she is probably, we're assuming that she's had some weight loss. She's having trouble with fluids. She's having trouble with food. I think at this point, it would be a good idea for her.
And I have a lot of people say, how exactly do I get fed? If you can talk about that, Carol, like how does the nutrition, the enteral nutrition get into the body? Like from a bolus,
Well, there's really about 3 different ways. So if I look at, what their needs are. So if they have lost hand function and they can't use their hands, well, it's going to be hard to do it by a syringe unless they have a family member that's willing to do it. So what it is bolus would just be using just a 60 milliliter syringe and opening the formula and pouring it in, and having that formula go into the tube feeding through gravity. And you can, they can feed themselves 3, 4, 5 times a day. Even during meal times, like regular meal times, doing it that way. If they do have troubles though with their hands and they don't have someone available just to kind of stand there for about 10-15 minutes to hold a syringe, I recommend gravity, ordering an IV pole, and there's just a bag that hooks onto the IV pole. The tube goes right into the port on the tube feeding. And there's like a little clamp on there, a rollerball clamp. They'll pour the formula into the bag, and the formula will go through the tube by gravity. And they can kind of, determine how fast or slow they want that feeding to go in. And there's also a pump, a tube feeding pump, which is just kind of a little small box, and we figure out what they would need. They plug it in it's like a little computer. They plug it in. They can feed themselves at night if they don't want to take up their day worried about tube feedings. They can feed over a 12-hour period, 14-hour period, and they can do it at night. They can do it during the day. They can, and it's basically based on what the patient's needs are, and the availability of someone to help them. And that's what we look at,
And so for me, in terms of assistive technology, because she is using a Trilogy during the day, as it is documented here, she is also using an iPad to communicate at certain times. And it is an iPad can have an application, a computer or a communication app. So anything that Adele would type into the iPad, it comes out in a computer synthesized voice. So she could use that. The significant other says Adele gets very angry when he tells her he cannot understand her. And that's actually very typical of people with communication disorders. They have expectations that their loved ones are supposed to understand them, regardless of how slurred their speech may be. So I would advise her to use compensatory strategies. So it helps if you have dysarthria, which is slurred speech, if you slow your speech down. And sometimes you need to over-articulate. But one of the most important compensatory strategies I educate our families on is that they need to repeat what they heard the person say, because that's where the anger gets in. An individual takes a deep breath, they try to say something, and the listener did not understand them. So they have to then take a deep breath and start over again. And at the third time, they're angry, or they're going to say, never mind. So family members and anybody else in the house should say, Adele, I heard you say you had a doctor's appointment. What day was it? So they're acknowledging they heard her say something. They're acknowledging what they heard her say, and they're only asking her to fill in the blank. And that also can reduce her fatigue, and it can reduce the anger that she gets. The problem is that when somebody is starting a sentence and the listener has missed a word, their brain basically just stops. They're going to perseverate on what's the word they missed, and they're going to miss everything else she said too. So acknowledging that what you heard her say and just asking her to fill in the blanks can reduce some of that anger, but also using the iPad. Or when she is on, as it says here, she's on the Trilogy during the day. When you're wearing a Trilogy, it's a full face mask most of the time, so it's taking up both the nose and the mouth. So she's going to have an alternative to communicate when she's using the Trilogy during the day, because it defeats the purpose of having a Trilogy if you keep removing the mask just to talk. So you would need to utilize the iPad at that point for communication when she's on the Trilogy. But we might also be talking about other things besides this. Her handwriting is slow and sloppy, so that might mean she might have some dexterity issues. So instead of just using her finger, maybe using a stylus is easier for her to access that iPad. So that's where I would work with the physical and the occupational therapist to say, you know, how is her hand strength? How is her finger strength? And then we talk about alternatives to access her communication device or her iPad. That's why we work as a team, so that we can bring other team members in to help us give the optimal care to each individual. So with that, do you guys have anything to add about Adele? No?
I would just, in the meantime, until, you know, if she does decide to do the tube feeding, in the meantime, I would give her some calorie packing, you know, strategies, extra gravy, sauces, things to make the food a little softer, easier to swallow. And, you know, hopefully we can kind of keep her weight at bay until she gets that feeding tube.
Well, now that you mention it, why is maintaining weight so important, Carol?
They in many studies that were done, and the latest study was done last April, where it showed of all the nutrition, you know, changes that you can make, the most important thing is weight maintenance. Anytime you lose weight, you lose both muscle and fat. And we want to preserve as much, you know, as we can. It shows that, you know, weight loss does unfortunately progress the disease. A little bit of a higher BMI is more protective. So we want to keep that, you know, keep that weight on as much as we can. Of all the nutrition changes, that's That's the most important thing that we can do.
But you know what we hear is, but I'm not doing anything. Shouldn't I be reducing my calories now that I'm not being as active?
Well, unfortunately, it's a high metabolic disease. So you're burning usually burning a lot more calories than you would, before you were diagnosed with this disease. So we do, even though you're not doing much, or you're not doing much, you're not as active, your body's still in that calorie burning stage. So we want to balance the scales a little bit, and we may have to eat actually more, and sometimes in some patients a lot more than they're typically used to eating. And if they're having trouble with chewing and swallowing, that's sometimes where that weight loss comes in.
And then lastly, Dan, could you talk about why you might recommend a video swallow? Because if people are trying to calorie pack, as Carol just said, eat more, obviously you want their swallow to be intact. So why would you recommend a video swallow? You're muted.
Okay, so just to talk a little bit about what a video swallow is. A video swallow is an objective instrumental evaluation of swallowing. What it does is it actually helps to look at the swallow function to rule out whether there is aspiration, and really to identify what the degree of dysfunction really is. There are two ways that we can actually do an objective or instrumental evaluation. One I offer in the clinic is called FEES, which is a fiber optic evaluation of swallowing. They both basically achieve the same result. The reasons that I would recommend those would be maybe for some people that are in the earlier stages, that have complaints that normally I couldn't, I'm not able to really identify, like in the clinical sense. So then we would need to go to pursue a more instrumental type of an evaluation.
And then if people do notice that they are losing weight, then they need to reach out to their doctor. And then, or the nurse practitioner at their clinic. How many times, when should people weigh themselves? Like weekly?
Weekly. I recommend weekly at least. Not daily. I think daily stresses some people out a little bit. And a lot of that daily weight can be, fluid losses or gains as well. So I usually tell them, if they're in Wednesday clinic, because we have clinic on Wednesdays, I will say, okay, every Thursday morning, same scale, no clothes or clothes. You have to make everything pretty much stable. And I will tell them, if you see a 3-pound or more weight loss in a week, contact your nurse and I'll get in touch. I'll get in touch with you. A lot of time, if they do not weigh themselves once a week and they wait, 9 times out of 10, we will see a weight loss because it sneaks up on people. So it's really important to keep an eye on that weight.
Okay, great.
And Adele is a returning patient, and is a patient that has been involved in research, as Laura will say in a minute. So we have known Adele for a while, and we also know that Adele is a patient who has a familial history of ALS and FTD, and has been testing positive for a particular genetic mutation, which is the C9orf72 gene. Obviously, that conversation and the genetic testing, the importance of the genetic testing has already been explained and went through by Dr. Ilieva and the possible genetic counselor. And so both Adele and the family know a lot about that. And they also know the importance of knowing this genetic mutation. Together with Laura, we continue to involve Adele and in our clinical research program, and to educate on the ever-evolving really knowledge, not only of the mechanism by which C9orf72 causes and triggers ALS and or FTD, but also the importance of the relevance for the ongoing clinical trials. Right now, Biogen has a phase 1, phase 2 clinical trial with the antisense oligonucleotides, which is, as I always tell the patient, a sort of reverse gene therapy for C9orf72. And so in that respect, this is a more focused for a patient who knows the cause and has a family history. Normally, the conversation that we have is really trigger all the our job in the clinic, my job in the clinic is really triggered by whatever question and whatever needs a patient like Adele has in that time. Patients come to clinic every 3 months. We, as a research team, really stays in touch with them on a regular basis throughout, in between the clinic visits, because again, mainly in these times, there is so much going on. Patients are incredibly well educated. This is their life, right? And they know, they read a lot about new press releases that come out from the initiation of a trial, like the Biogen trial for the antisense, or a new article that may have come out that showed that perhaps there is also the possibility, again, in the context of C9orf72, to begin an immunotherapy that is using antibodies that target some of the toxic products of this defective gene in ALS. So patients stay in touch with us and they want to know what we know about it, when these trials will be available, and what has been the reasoning, the rationale, and the research behind that. So this is normally what, for a returning patient who has been involved in research, I do. I continue the conversation that never stops, really, when I'm in clinic.
Yes, so many of our established patients, such as Adele, will we already have a research relationship with them, and they may well be enrolled in the trials at Jefferson. One such trial that we have is our biobank program, where we look to collect blood and or urine from patients during their clinic visits. So I may well be going in to see Adele during her visit to collect these samples if she's still willing to give them, and take those back over to the lab so that we can use them for our basic research. And as Piera was saying, we keep a really open conversation with a lot of our patients regarding upcoming clinical trials and trials that they may be eligible to be involved in. So we continue to have this conversation.
And maybe Laura, you want to say a little bit more of what is the process, right? So you said that you take the samples, you continue to take the samples because Adele is a patient who is enrolled in our biobank. Every 3 months we take a sample, but what is it our ultimate goal? When you bring it back to the lab and you process those samples, we want to identify biomarkers of disease, right? Maybe you can say a little bit more of what that entails, and what is a biomarker, and eventually what is a therapeutic target.
Yes, so many of you will be aware that ALS is an extremely complex disease. There is an extreme amount of variability between patients, clinical presentation, within genetics, and also at the molecular level. Really a big push for our research and how we believe that we're going to really improve the development of effective therapies is really to start looking at patients as an individual. Yes, every single patient may well be diagnosed as an ALS patient, but that does not mean patients can be treated the same. And it may well be that we need to find different effective therapies for each patient or each group of patients. So really our research is to try and study as much as we can, as I said, from an individual and also between individuals. So in collecting samples for our biobank program, this really allows us to take these signatures back to the lab and really look down into a patient's individual cells to really compare and say what's unique about this patient, what might be different, and how can that be taken to create an effective therapy. Is that okay?